Hi, good evening, everyone. Thank you very much for joining us this evening. And I'm happy to be your host. I'm Dr. Dan Tumani Mafujani, and we'll be kickstarting our National Oral Health Month with one of our webinars. And we do have our guest speaker, Dr. Johann Lochner, who I'll introduce later on. I also have with me now in attendance Dr. Hanil Bana from Colgate, who SASPIO has proudly partnered together in this National Oral Health Month to bring you this webinar. I'm going to quickly hand over to Dr. Bana, who's going to give us a few words from Colgate. Dr. Bana, over to you.
Good evening, everyone, and a very warm welcome. My name is Dr. Hinal Bana, the Scientific Affairs Manager at Colgate, and it is my pleasure to welcome you. On behalf of our entire team, thank you to our incredible partners, SADA and SASPIO, for making this webinar possible. Colgate is deeply committed to supporting the growth of dental professionals and to partnering with you to improve oral health, not only in South Africa, but globally. We have an insightful presentation ahead with Dr. Johann Lochner. So to kick things off, we're going to share a brief video with you on the advanced science behind our new Colgate Total Active Prevention.
Prevention is power. Colgate Total's new prevention technology fights dental plaque, the root cause of many common oral health issues, helping stop those problems before they start. To fight dental plaque, many formulas use stannous fluoride, powerful but highly unstable. It can degrade quickly, reducing the toothpaste's effectiveness over time. Unlike others, Colgate Total's patented technology stabilizes stannous fluoride using a novel combination of two known ingredients for three key benefits. 1. High bioavailable level of the stannous active. 2. Long-lasting efficacy. And 3. Enables customized formulas through sensory science for specific needs. Colgate Total's new prevention technology. Preventative, powerful, and patented science that helps fight the root cause of many oral health problems.
Thank you all and enjoy tonight's webinar.
Thank you so much, Dr. Bana, for those words from Colgate. It's always a good partnership with SASPIO to have Colgate backing us and together with SADA. Ladies and gentlemen, it is my pleasure at this moment to then introduce to you our guest speaker for this evening, Dr. Johann Lochner. I'm going to read a brief CV about Dr. Lochner as I introduce him before he starts. Dr. Johann Lochner is a specialist in oral medicine and periodontics from Somerset West in the Western Cape, South Africa. He lives there with his wife Alette and two sons, JC and Francois. He grew up in the Overberg, a rural part of South Africa, near Bredasdorp, close to the southernmost tip point of Africa. Dr. Lochner graduated as a dentist from the University of Stellenbosch in 1996. He worked in private practice from 1996 to 2001 in Ramsgate and Margate in England. During that time, he studied part-time and obtained the MFGDP, which stands for Membership of the Faculty of General Dental Practitioners for the UK, which was a diploma in 2000 that he received. He left private practice in 2001 and worked as a senior house officer at the Newcastle upon Tyne Dental School, and he obtained the membership of the Faculty of Dental Surgery from the Royal College of Surgeons of England in 2002, MFD RCS England. During 2002, he returned to work in private practice in Beckenham, Kent in the UK until he returned to South Africa in 2004. He then specialized in oral medicine and periodontics and obtained the MCHD in oral medicine and periodontics in 2007 from the University of the Western Cape. He has lectured and published both internationally as well as locally on periodontal topics and the replacement of teeth with dental implants. Since 2007, he worked full-time in private practice in Hout Bay, Belleville, and Somerset West near Cape Town. He was president of the South African Society for Periodontology for 2 terms, serving on the EXCO of the South African Society of Periodontology and Oral Medicine for over a decade, as a vice president of the Cape. He served as a vice president of the Cape and then Society of Dental Implantology, CSDI, and later the SAAO, and serving on the ESCO for almost a decade. He is an ITI fellow and served as a study club co-director and director of the IT Wineland Study Club. He is currently the president of the ITI for the South African division. He is in private practice limited to oral medicine, periodontics, and dental implant surgery. And he is also a senior consultant at the University of Western Cape, Department of Oral Medicine and Periodontics. He is involved in training of registrars in the field of dental implantology. And without any further waste of time, Dr. Lochner, after that short CV, allow me then to hand you over to our guest this evening, and you'll be giving us a talk on a very important topic to kickstart the National Oral Health Month, which is the management of periodontitis in private practice. It is a very important topic, and we are hoping to hear from you and learn a lot from your talk this evening. Dr. Lochner, over to you. Thank you.
Well, thank you, Dan, for that introduction that actually made me think of where I've been and what I've been busy with for all these years. Yeah, so thank you for that introduction. Thank you to SASPIO, with which you obviously are on the EXCO, Dan, and Dr. Suzette Stander for the invitation from SASPIO for me to give a lecture. And thank you also to Colgate, which is not only a partner and a sponsor, but they also obviously have amazing products which we use in practice every day. So I'm going to see if I can arrange my screen so I can start with my presentation.
While we're waiting for Dr. Lochner to set up, ladies and gentlemen, just a friendly reminder that at the end of the talk, we'll be taking your questions. Please feel free to type them in the chat, and Dr. Lochner will be happy to answer any of your questions. Thank you. Johann, over to you. We can see your screen.
Right. So I'm on, and then I can get started. All right. Yes. So my topic that I've discussed with Dr. Stander is to give you an insight on how I manage patients in my practice, which is a private practice limited to periodontics, oral medicine, and implant surgery. And I just want to share with you how I basically treat patients when they refer to my practice, or manage and treat patients, even if they're not referred, but if they come on their own steam to my practice. So I hope you find it helpful. At the end of the lecture, I'll also share my contact details if you want to get in touch with me via email. Okay, so let's just look at a few terms that I want to clarify in the beginning. So what is periodontitis? I mean, we can all Google that. We can all go to our textbooks. But for me and for my patients, I explain periodontitis as a severe form of gum disease. In periodontitis, the gingival health has been lost, and the patients develop, from a healthy situation, they develop gingivitis. Now, this gingivitis progressed then to periodontitis. In certain patients, that's susceptible. And in the end, the supporting tissues, this includes soft tissue and the bone, is affected by periodontitis. Now, if the disease is left to progress, there's a lot of issues that arise. Poor aesthetics, teeth get loose, teeth are lost. And then something that has been a fact for a very, very long time, decades, is the very close relationship that periodontal disease has, and it has a very serious effect on systemic health of our patients. At the moment, that has sort of had a little bit of a resurrection when patients have asked, and when the press, especially about the link of periodontitis causing dementia for interest's sake. So another thing that I want to clarify is the term management. Okay, so the management of a patient includes that very first and initial visit that the patient attends my practice. And it involves the examination of the patient. And then, very important, from that examination, one needs to determine a diagnosis of the specific problem that the patient has, being it periodontal, tooth decay, oral medicine related, but a diagnosis needs to be noted. And that's obviously also the ICD-10 code that's going to be used when you report on disease and for quotation purposes where your ICD-10 codes are important. Then as part of the management, the treatment of the patient. And as important as the examination, diagnosis, treatment, none of the treatments we do in practice in periodontics is successful without a very rigorous maintenance program. I'm going to also focus on something that's very important for me in practice, and that is optimizing patients' healing potential. I'll talk about that as well. And extremely important, these things that I've mentioned on the slide above, each one of these things are done specific for each patient. I mean, I often get the question when I put a radiograph on screen, the patient would go, "So doc, is that my x-ray?" And I would say, "No, it's just a generic one. We show the same one to every patient and we make decisions that's blanket the same for everyone." It's obviously not like that. So I make an inappropriate joke, but obviously tailor-made, each patient receives his own treatment plan. And obviously there are generic things that we do the same for patients, but specific for each patient. Okay, so I'm in private practice. And that's where I do, I would say, 95% of my work. But from the screen, which I can't see the number of participants yet here, so the odd 270 of you that's attending tonight, not all of you work in private practice. You can be in a busy city practice that's high-end patients. You can be in community service sector, or you can work in a rural part, like where I grew up in a place like Bredasdorp. But I would always come back and when I think how I manage patients in my practice, I would always say that you must conduct yourself with your knowledge and what you do in a way that you are going to treat somebody that you like. I wanted to mention a family member, but I mean, not all of us like all the family members we have. So I would, that's why I changed it and I said, treat everybody as if you're treating somebody that you like. And I think if you take that message home, what you do in your practice, wherever you work, I think you'll be happier. You make better decisions, and you'll be able to have a good night's rest when you know you've done your best. Okay, so I'm going to talk about what I do for patients in my private practice for periodontics by using a specific example of a patient that I've been treating for, goodness, yeah, it must be coming to over a year and a half now. But let's go through it. So this patient presented to us. He was referred by his dentist, and he attended for that initial visit. And that's a very important thing. I mean, a patient that books an appointment firstly at my practice that comes for a consultation after his dentist has told him to come to me, I know already that that patient is serious and he already understands that there's something that's not right. So patient comes in, so he says, my teeth are loose, my gums bleed, I have pain when I eat my food. Now, this man is a winemaker. He has his own wine farm. And for him, the fact that his breath is not smelling so nice and that he has a taste disturbance is a huge issue. And I think the few things mentioned above, the gums that bleed and the pain and my teeth are loose, probably for him was important. But the fact that he was starting to lose his sense of taste, extremely important, because that is his profession, it's his livelihood that was starting to be affected. And together with that, I mean, being an owner of a wine farm, he also didn't like the way his teeth are looking when he smiles. Okay. So when a patient comes to my practice, what do? I always start to maybe break the ice a little bit and ask the patient, so what are you here for? And then you get the question from, did you not receive those records my dentist sent? I mean, you should surely know what I'm here for. I mean, and then you get that patient that sort of, you can see they immediately sort of on the defense or they're aggressive. But you must understand, patients don't like to come to the dentist. I think we know that. We all work in dentistry. They don't like to come to us. They know they're not only going to be treated that will involve discomfort, pain, but they're also going to have to part with some cash that is uncomfortable for them. So always good for me to start on a light-hearted side and ask them specifically. And if they are that patient that says, well, did you not read the letter of the referring dentist? I said, yes, I read that. But I want to know what you are here for. What do you want to achieve from this visit, firstly? What is your endpoints? What is your treatment outcomes that you're looking for? What do you want me to do for you? And where do you want to be at the end of treatment? So at least it's a very good way to get a nice history from the patient, where they want to go and what the expectations are. Now, this man, from that chat that started, we obviously started to talk about wine, which I love. I'm living here in the winelands in Somerset West. So that was obviously a very nice point of talk. But from that, I extrapolated that he's not very keen to go to the dentist. And no wonder, I mean, he's had neglected his oral hygiene in his mouth for quite some time. Previously heavy smoker, and the heavy smokers and the patients that tell you they're not so heavily smoking anymore, you always have to take that with a pinch of salt. I mean, I would always probably double what the patient says they're smoking every day. So we obviously have a medical questionnaire that the patients fill out, and from that, he ticked boxes that he had some issues with his cardiovascular system. He had angina before, hasn't had a proper heart attack yet. But he said he was seeing somebody that started to look at management of cardiovascular issues. He was on blood pressure medication. He also had a previous ulcer, which pointed to me that he was I mean, not everybody develops an ulcer. That usually comes with smoking, bad habits, and then also a lot of stress. On top of that, he was diagnosed with type 2 diabetes. He had cholesterol issues, he had asthma, and let's just say he wasn't a skinny man. So obviously some issues with his weight as well. So that was just sort of a general chat and looking at his medical history that we got those bits of information from. Then obviously, as part of that, what do you do here in my practice? we're obviously going to do an examination for the patient. We're going to have to look at his teeth. We're going to have to look at his mucosa. And I always look at, as I think about it, and as I like to explain it to my registrars that I teach, I like to look at what parts of the patient is visible. So it's not always only the face, it's the arms, if they're short sleeves, it's the hands, the legs, the color of their skin, the color of their eyes, their complexion, the color of their hair, if they're bruised, if they appear pale, how they clench their hands when they sit in your chair, how all these little subtle signs. So yeah, just open your eyes and look at the person in front of you, and don't only just jump in and have a look inside their mouths. Okay, so as I mentioned in the beginning, there's been a lot of very strong associations between periodontitis and numerous serious systemic issues. Now, if we can sort of grasp back at this man's medical history, he's got quite a few boxes that's ticked and that has effects systemically. I mean, he's got issues with his cardiovascular system. He has diabetes. Okay, fortunately, he has never been pregnant, but he's got respiratory disease. I mean, he's got asthma. Then the chronic kidney disease, he doesn't have chronic kidney disease, but he has high blood pressure, and the kidneys play an integral role in the regulation of blood pressure. Doesn't have rheumatoid arthritis. The one that I've mentioned that's quite a big thing at the moment, where we've had a few phone calls and said, Doc, is this dementia caused by my periodontitis? So yeah, and he hasn't got issues with that yet, but he has an issue with his weight, and the last two boxes one can speculate on. But just remember that periodontitis has a serious effect, and there's a cause-related effect as well. So what that means is, especially with atherosclerosis, diabetes, and adverse pregnancy outcomes, there's been randomized controlled trials that were done that shows that takes two different groups of patients. Those that's got disease, periodontitis, and those that has the systemic issue as well. And if you treat the periodontitis, treat the outcomes of their systemic health issues improved significantly, especially for the top three. So yes, it's extremely important to diagnose and to obviously treat periodontitis for patients. Okay, so what do I do for the patient? Obviously, one needs to do a periodontal assessment. I do that with a periodontal probe that's obviously marked off in little millimeters. And that is crucial. You need to do a periodontal examination, and you need to record probing depths for your patients. There's a lot of online forms that can be downloaded, but you must have a record that this pocket charting happened. Okay, as part of the periodontal examination, we don't only do a chart, we also look at the mobility of teeth. And I use this charting system, which is probably known to a lot of you, and maybe a lot of you don't know it, but I've been using it for a long time. So I'm sort of stuck in my own bad habits. I'm sure there's nicer ones available, but I stick to this one. Bottom line is, I can record probing depths, I can record mobility and recessions. So you'll see there, I can't use my cursor on the screen, which I'm sharing to you at the moment, so I'm just going to have to explain where you have to look. You can see from this, there's buccal, and then it says PD, which means probing depth. And you can see that the probing depth for this patient varies between 4 and 8 millimeters, more or less. You can also note that the next line says REC. That is the recession that needs to be noted. And you can see there's a lot of zeros. So when this patient presented, didn't have any recession. But you can also see there in the MOB line that there's a few 3s there. That means that the front 4 teeth were grade 3 mobile. Then on the bottom part of the screen of that assessment chart, I always say to patients, the little pieces that go black are beautiful. The yellow ones means there's a problem, and the red ones means there's a big problem. I mean, and that obviously relates to probing depths of 1 to 3 millimeters, which are normal. Probing depths of 4 or 5 millimeters, which are a problem, but not so bad. And then your probing depths exceeding 5 millimeters are problematic. Those are seriously deep pockets. That is the probing depths on the pocket charting, mobility and recession chart of the lower teeth. And you can see there the date stamp was the 12th of July of last year. Now, on his lower teeth, you can clearly see in the middle that there's been, on the REC bar, there's not only probing depths, but there's also a lot of recession and then also mobility. Now, there's a term that's used. It's obviously a probing depth, there's a recession. But if we want to evaluate the attachment of a tooth, we call about the clinical attachment. And when you look at the clinical attachment or the loss of clinical attachment, you basically add your probing depth to your recession, and the two together equates to that clinical attachment loss. So that's a calculation. So you can see if you add those two together for those front teeth, if you add the 5s together, it gives you a clinical attachment loss of 10. Right, very important. You must note the plaque index and do a plaque score for the patient, and you must also do a bleeding score for the patient. This is very nice as an education tool. You'll see his plaque index was of 62.5%, and 94.6% of the areas bled when you poked him with the periodontal probe. That must be noted down. That's extremely important. All right. I mean, he was uncomfortable when I looked at him. So I was looking for a patient to present for this lecture, and it was always difficult for me to find pictures that's usable to make a few points. So for me, when I mentioned you need to look at his occlusion, you can see there that his upper left lateral incisor is chipped. But this man had a crossbite. So when he bit together, that lateral incisor was biting right towards the lingual of that bottom left canine tooth. So look at the occlusion as well. Get the patient to bite together. And very important, note if there's traumatic occlusion. That means when the patient bites together, you want to see if his teeth moves. Now, when this guy talked, you could always imagine that his teeth were moving. That's how loose his front teeth were. Okay, so that's our periodontal assessment. Then, as part of his management, it's essential that we take images. Now, I received this image from his dentist. Okay, and this is an extremely useful screening tool for patients that you examine in practice. Very important to have a pan-oral radiograph available. Okay, but guys, a pan-oral radiograph is not something that we use to make decisions on. We count teeth on them, and we can see that the patient has an issue, but we can't see how severe the problems are. We need bite wing radiographs, and by the time a patient has severe periodontal disease, a bite wing often misses the bone. The bone is often lower than what the bite wing gives, and one needs periapical radiographs. These are important. Okay, so these were the periapical radiographs that I took of the patient and that I put into the slide for use over here. So I don't think it's difficult for everybody to see that there's bone loss, and I don't think it's difficult to see that there's a lot of hard tissue deposits sitting on the teeth. And you can see significant bone loss on the maxillary anterior teeth and the anterior mandibular foreteeth. And those were the ones that were also already mobile. Then I want to make a very important point. For periodontal treatment, a CBCT is not what you make your decisions on. You make your decisions in practice. In my practice, a patient that has periodontal disease is diagnosed with a pan-oral periapical radiographs. That's the standard of care. A CBCT is not the standard of care to diagnose periodontal disease. Together with your periodontal chart, periapicals are more than sufficient. Yes, I am going to talk, we are going to look at this patient later on with a CBCT, but I'll address when that is required. Okay, let's look at the following part of the management of the patient. So once we've examined the patient, once we've had a good chat with him, once we've actually looked inside his mouth and evaluated his teeth, his hard and soft tissues, there's a discussion that needs to happen. And you obviously have to answer a few questions to the patient. Doc, can we save these teeth? And for this, there's not a generic one size fits all. You need to look at each tooth individually. Okay. This is also the time that you need to then consider additional records, intraoral scan or study models. And when I looked at this patient, I knew that it was going to be important for him, preferably to have some kind of orthodontic treatment to manage his anesthetic splaying front teeth and the fact that he had a crossbite as well. Okay. This is something that in private periodontal practice has become very important for me. But guys, these are things that you can also, if you're interested in periodontics, and long before I became a periodontal specialist, I was intrigued by periodontal disease. I know it's a bit weird, but anyways, we are a bunch of weirdos that studies dentistry. And I started with my periodontal practice long before I became a specialist. And it's important, if you want to know about these things, read up on them, go to additional courses, attend these webinars and things. And yeah, these tests, these additional tests that I mentioned over here are extremely useful. So I'm going to do a full blood count for the patient. I'm going to evaluate their sugar. And we don't do a glucose tolerance test or a fasting glucose anymore. We do a HbA1c that looks at their glucose history. Then very important, I do an iron study, and that looks at their serum iron. It looks at their serum transferrin saturation, and ferritin. So it's not good enough to just do a hemoglobin. And that's what the poor patient often arrives with from his normal doctor. Doc, I'm fine. I had a hemoglobin done. It's not good enough. You need to do an iron study for these patients that you identify that's got serious issue, like obviously this man had. Then I do a vitamin D test for my patients. I also do a vitamin B12 and red cell folate and serum folate. That is the standard recipe that I do to evaluate patients. Not every single patient that comes to my practice that's got gingivitis, but patients that's got periodontal disease, I evaluate with these. And a lot of patients already have got blood tests available. So I asked them if they had blood tests in the last year or so. And then we can get a cumulative test result from PathCare or whichever company they've gone for their blood test to. I will look at what's available. And if I'm happy, no further tests, but if there's ones that I'm interested in that's not been done, we send patients selectively to have those extra tests done. Okay, so let's look at blood test results quickly. So you'll see here, this patient had a full blood count. You can see there, and it's not difficult to see that there's some flags. Flags meaning there's some high spots. So this patient has a high white cell count. his neutrophils are high, his monocytes are high, and his immature granulocytes are high. These are all linked to systemic infection. Okay. Now he has a systemic intraoral infection, periodontitis, that affects his health. So it's not weird to see that there are some elevations there. Okay, he's diabetic control. I mean, he's been diagnosed with diabetes. He's taking glucophage. So what was interesting is that it appeared that his glycemic control was okay. I mean, he was under, it wasn't flagged as high. He was below 5.7. Then a very important thing is anemia of chronic disease. Now, that is something that you can go and read up on your own, but basically it means that patients that's got a low-grade chronic infection of some kind in their system become anemic, not due to an iron deficiency, but due to the chronic inflammation that their system is under. Now, this guy also had a high ferritin. You can also see the flag there, 409, high ferritin, which was caused by his hyperinflammation due to his periodontal disease. But classically, in a patient that has anemia of chronic disease, that ferritin can also be low. It can be 40. As soon as it's below 70, there's an issue. Now, the problem with anemia, being it iron deficiency anemia, vitamin B12 related anemia, or folic acid related anemia, there's all different types of anemias caused by these deficiencies, and I'm not going to go into them. We can talk all evening just about anemias, but I'm going to mention it to you. The bottom line is, if you've tested your patient for these things and you see flags, then you need to decide, are you either going to manage these things yourself? And for that, you need knowledge. If you haven't got the knowledge, you have to refer the patient either to their doctor or to a physician for them to be evaluated and managed and treated for this. You can see here that this patient had a vitamin D level of 30. Now, you'll see in the description there, if the patient has, according to Mann et al. 2016, a vitamin D level of above 20, they're okay. I mean, it says the optimal level above 20. Guys, I'm going to show you some figures shortly. A vitamin D level of 30 is not even enough for a patient that is sick. You'll see here his vitamin B12 level was 703, and the reference range is about 185 to 250. We want a vitamin B12 range of above 300. Okay, 285 doesn't quite do it. Above 250 doesn't quite do it for his patient that is sick. And the problem comes in with iron deficiency, folic acid deficiency, vitamin D deficiency, and B12 deficiencies. The patient has poor oxygenation in their blood. Their immune system are in imbalance. As we say in the industry, they have a high oxidative stress and they're hyperinflamed. They are systemically inflamed. They need something to fight that with, and they need their blood profile to be optimal. Their immune system needs to be optimal as possible for them to get a good outcome to treatment. Okay, so these people that's deficient, they're in any or many of these things, they're prone to infections. And this can be the reason why we said patients that has gingivitis doesn't all progress to periodontitis. It progresses from gingivitis to periodontitis in susceptible patients. So they can be genetically predisposed. Yes, I get that. They can be predisposed because they're smoking. They can be predisposed because they're diabetic, or if they've got a bad biofilm. And those are the major risk factors for periodontal disease. But the blood profile of a patient has a huge impact on risk. So it is something that we test routinely. All right, let's go to vitamin D. Okay, before that, I see there's another slide. I just draw in another slide of a different patient that shows here that I looked at an iron profile, and you'll see here that this patient's ferritin is low, 29. Okay, and that's your classic patient that's got a hemoglobin that is low in this case, but sometimes the hemoglobin can be low. So this patient had a normal red blood cell count, the hemoglobin was low, and a few other flags as well. You can see the ferritin is low. So this patient is anemic. Okay. And on top of that, you'll see here that this patient also had a low vitamin D level, 13. Okay, so that's a proper flag of a deficient vitamin D. Okay. So vitamin D is an extremely important factor, and it's becoming more and more relevant in my practice. The effect that vitamin D has on the immune imbalance or balance of a patient. And you'll see on the right-hand side of the screen there that the levels that is mentioned by PathCare as being deficient or optimal is not close to being optimal. I mean, if we've got a patient that has disease, especially if we look at a patient that's got diabetes, whose oxidative stress is in the red, we need an optimal level of up to 80 nanograms per milliliter of vitamin D for these patients. Yet if we look at the vitamin D levels that's been done by their medical doctor, as soon as these people or these patients have a vitamin D level of around 20, 25, the doctor doesn't even give a supplement. But these patients are supplemented, I supplement them in my practice to optimize their healing. So you can see on the bottom of the screen there, there's also some recommendations on how many units per day that you have to add to get an optimal level. And I got these new bits of information from a colleague of mine, Dr. Whiting, who is a dentist working in Wellington. So thank you, Jacobet, for sharing these to me. And I can just stress that it would be very interesting, and I would urge all of you that sit indoors all day looking at teeth to do yourself a favor. Go and do iron studies for yourself. Look at your vitamin B12, folic acid, and take a test for vitamin D. And that old comment that says, Doc, I'm an outdoor person. I mean, I cycle, I surf, and all these things. You have to be in full sunlight with your extremities open for about 2 hours to generate the desired, say, 10,000 units per day. As soon as you put on a factor 15 sunscreen on your arms, you block out the sun completely, and it has zero effect. So your skin can't manufacture that vitamin D. And then everybody's scared about skin cancer, so we cover up. We wear long sleeves. And those of us which complexion is not white, we take double the amount of time to generate the right and correct amount of vitamin D. So most of us, including the person giving the lecture tonight, is deficient in vitamin D. And you wonder why you feel a little bit tired, or you just not running on 12 cylinders. So guys, go and test yourself. And you'll be surprised what you find. So vitamin D, extremely important. Right. The diagnosis of periodontal disease is crucial. You must determine a diagnosis. So there are 2017, that's our new classification of periodontal disease. I'm not going to delve into the classification, but we need to classify the disease and we need to stage it. and we need to grade it. And for this patient, I can't read it out to you at the top of the screen there, but this patient was diagnosed with generalized periodontitis, stage 4, and he's got a lot of modifiers: diabetes, smoking, anemia, obesity, asthma, highly stressful job. So it is, as I call it to patient, it's a perfect storm. Dr. Rajkumar, one of the registrars at UWC, shared this article with me. And I think that's a very nice one for you to just go and look at 2019, and it's the implementation of the new classification. It's a very nice way, and it's got these little flow charts for you to see how you diagnose and what do you have to do to look at it. So I'm not going to go into the diagnosis or of that. Go and read about it yourself if you want to. There's the slide. Okay, so now management decisions. The patient needs emergency treatment. He's got pain. He's got loose teeth. Now, with anything that we treat in practice, if you don't remove the cause of the problem, you can't eliminate the problem. And extremely important, we're going to have to manage the patient's risk factors. And we're going to have to optimize the healing potential. We spoke about that. And rectify that with what we find wrong in blood tests, for instance. The smoking, management of diabetic control. And guys, all these things that I've mentioned above, you can all do this if you're interested in it. And if you want to become interested in, then do it for your patients. But if you do not, and if you're not interested in these things, that doesn't mean you must not diagnose and manage all the things that I've looked at above, maybe not all of them. But if you're unsure and you don't want to get involved with these things, that's where I think it's extremely important to offer that patient a referral. Okay, refer the patient accordingly. Refer them to a periodontist. Refer them to the perio clinic at UWC. But if you're not interested, don't withhold that patient's management. Don't withhold that part because you're not interested and you cannot do it. Send it along. Okay, so let's go to our patient. So the first thing is those loose teeth. I just put wires on them. His teeth were so loose that I splintered them on the buccal and the palatal part. Then you'll see on the premolars, I added a little bit of resin on the premolars because he had traumatic occlusion and he had that cross bite. So I added some resin to open the bite slightly to take the occlusal trauma away. Then, very, very important, there is no point in giving the patients antibiotics without non-surgical periodontal treatment. You need to treat the periodontal disease by cleaning the teeth properly, and that is when you can use antibiotics. So don't give antibiotics as a standalone. You must give it as part of root planing. Call it root planing, call it cleaning. I call it cleaning the teeth. You need to clean the teeth. You need to clean everything off the teeth, which includes root planing. And important on that, guys, I often get the comment that, Doc, I'm here with you. The dentist said you're going to cut my gums open and you're going to have all this surgery. Goodness, I wouldn't go for consultation if somebody warns me that everything's going to be slashed open and cut open. I'll be honest with you, I probably treat less than 10% of my periodontal patients in my private practice in Somerset West with periodontal open flap surgery. 90% of patients respond extremely well with just standard cleanings of their teeth, which involves removal of the supragingival and subgingival deposits with root planing. Okay, extremely important. The roots needs to be cleaned. Okay. So in addition to this patient, we added for this patient vitamin D, 50,000 units per week, together with vitamin K2 and magnesium to boost the absorption of this vitamin D. And we wanted to get it to a target of 60 to 80 nanograms per milliliter. Then after we did the root planing for this patient and cleaned his teeth, for each patient, determine an oral hygiene recall interval. If you haven't got an oral hygienist, I'm very fortunate to have Stefani and Kylie that does this for me. So determine where the patient fits in with repeat visits. 1 month, 2 months, 3 months. You need to make sure that the patient is listening and that they're cleaning their teeth like they should do. And you or your hygienist need to be removing supragingival and subgingival deposits if they occur again. Then, very important, you must re-examine the patient. And this patient, I re-examined, I think, at 6 months. Now, you'll see at the top part of the PD, so you'll see that his probing depths, his deepest probing depth that remained after just root planing his teeth was 5 millimeters, and that was on the 2-1. You can see there the distal pocket. And then on his lower teeth, all the pockets responded. His deepest probing depth, 4 millimeters. So for all practical reasons, I mean, the patient was cured by just cleaning his teeth and optimizing his healing with giving him supplements and using a combination of amoxicillin and metronidazole as part of his root treatment to manage his disease. Okay. So that's what the patient presented to then at that recall interval. You can see from the left side of the screen, we had inflamed gums. Now he had no gums. So a lot of the effect has happened with recession. Okay. You can see by now, he was also attending the orthodontist, which has started with orthodontic forces, to manage his crossbite, because I mentioned to him from the outset that you are going to lose your front teeth. And he said, no, I'm not. I'm here for treatment. You're going to treat me and you're going to save my front teeth. And I said to him, you're going to lose your front teeth. There's nothing I can do with grade 3 mobile front teeth. But we are going to keep your front teeth as long as we can, because what else is the option? We can give him a denture. We need to give him a bridge. But how are we going to get him through orthodontics without something that resembles teeth? So as I put it, we're going to put them on the washing line and we're going to keep them as long as we can. And just amazing how he responded. This was not long ago. I mean, it was on the 11th of August this year that he came for another reevaluate probing depth. And he had no pockets on the anterior component, even those very mobile teeth that's being kept in his mouth with orthodontic wires. No probing depths over 3 millimeters in the anterior. Yeah, some pocket areas right on the distal of his upper molars, but that's why he's coming for recall. And that's why we just carried on cleaning his teeth for him and making sure that he adheres to his periodontal maintenance program, hygienist visits every 3 months. So this was in the early part of this month where I took another picture of him. His front teeth are still there, but guys, I told him from the outset, you're going to lose your front teeth. And by now, after a year of treatment, or a year and a half, he's made peace with the fact that he needs to clean his teeth. He needs to come for periodontal maintenance. He needs to attend. He needs to spend money and time to keep his mouth healthy. And you can see there's no bleeding anymore. I mean, you can see that his mouth is healthy. And it is at this stage, when the patient is periodontally healthy, that we take, and we can take a CBCT for the patient. In my practice, we do a lot of implant work as well, but we don't do the implants on day 1 when the patient attends with their loose teeth and their periodontal disease. We treat the periodontal disease first. Now, when the patient's periodontal disease is stable, it is now where we can take a CBCT and we can plan for implants. I just want to see if I can go to the previous slide. Okay, this one over here. Now, I neglected to show you. Look at how this person now cleans his teeth. This guy had a bleeding index of over 90% when he came in. He now has a bleeding index of 8%. It's only a few of those front teeth at the top that bleed when you poke them. So his systemic inflammation is treated. His periodontitis is treated. And this will have a massive effect, a huge effect on his systemic health, his diabetic control, his cardiovascular disease, his asthma, all these things, it has an impact. So very important. And this is the key thing that we want to achieve for our patients is oral health. Okay. Now, if we go now to the periapicals that I took off those front teeth, you can see, yes, they still have no bone around their apices, but they've been retained for the treatment up to now, and now his periodontal is stable. So now we plan for implants for him. And I said to Dan, I have got Springbok colors in removing loose teeth. So yes, I extracted these 4 front teeth. They're gone. We used guidance to put his implants in the correct position where we project his orthodontics is going to end. Okay, so we planned that beforehand. He's not finished with his orthodontics yet, but with digital planning and guided surgery, we can project where we want to end up with our orthodontics, and we can place our implants with that in mind. Okay. This is something that just as part of his management, I used as an analog guide to verify my implant positions as well. You can see there they've got holes there. So I use this as a guide as well. But very importantly, you can see on the canines and premolars, there are little wings as well. So that was a backup plan, which actually was useful in the end for him because we planned to temporize these immediately on implants. But when we did the surgery, I ran into a bit of a problem with primary stability on his implants. And you'll see on these upper left lateral incisor implant, there's a little membrane tacked. So I had to do a little bit of bone augmentation on that left implant as well. So what you can see on the screen towards the bottom left-hand side is me just bonding my surgical template on. And there we have now a fixed option, a fixed provisional for our patient while we wait for his implants to integrate. Okay. Right, so that is coming towards the end of my presentation for tonight. So for me, very important in the management of the periodontitis patient, very important, examine your patient. And we saw that in the beginning, examine extraorally, intraorally, periodontal charting, note bleeding index, plaque index. Very important, diagnose the patient. And for those of you that's not interested in periodontal treatment, refer the patient. But for those of you that doesn't want to treat, for those of you that want to treat the patient, then treat them. Okay. And you can generate an income for these items. You can generate an income by charging a consultation fee, doing radiographs, doing models, diagnosing the patient. There's codes for examining the patient. Then there's a code for treating the patient. There's a codes for cleaning the teeth, for giving oral hygiene instructions. There's codes for root planing, and general dentists are allowed to charge all these codes. So guys, it's not for free. Then, important, the maintenance. Patients needs to be maintained, customized for each and every patient individually. They need to be seen for recall intervals, either by yourself for hygiene or by the oral hygienist for hygiene. Again, a practice builder and an income generator. Then you saw how I look at blood tests and my philosophy about optimizing the patient's healing potential and optimizing their immune system. And this needs to be monitored. It's not a single test that you do and forget. If your patient is being managed by the doctor, then it's obviously not your problem. But if you're going to have send it to the physician, then obviously they will do it. Or if you do it yourself, I usually look at review blood test at 6 months. And if things are still not like I want them to do, then I would refer them on to a physician for additional help. But I will optimize the healing for them. It's individualized, specific for each patient. And remember, no definitive treatment, and that includes specifically implant work, is done before the patient is periodontally healthy. Periodontal health is essential before you go to these treatments like implant treatment. Otherwise, your implants will fall out, guaranteed. Okay, so with that, I thank you for your attention, all 313 of you that sacrificed your Tuesday evening. I hope that many of you could at least have a nice tea or coffee or something else that you like, and I hope that I was able to not let you fall out of your sofa onto the floor with boredom. And with that, Dan, I'm eager to take questions if there are. And for those of you that feel that you don't want to ask the question on the platform, I'll answer as far as I can on my email, which is mentioned there.
All right, Johann, thank you very much for a very educational talk. And like you rightfully said, we still have a full house in attendance, about 311 attendees. And thank you very much, ladies and gentlemen, for staying online, and even to those who are watching us on YouTube. We do have a couple of questions in the house, I think 8 in the Q&A, Johann. And just
Okay,
to get
I'll go
the
and have a look there. Yes.
Yeah, I'll read some to you to answer. Before I do that, I wanted to just ask. In fact, I wanted to compliment you for putting into sharp focus the concept of periodontal medicine. You know, we often talk of periodontal medicine, and that links up nicely with how, you know, oral health is part of systemic health. And being an oral health month, it's important that, you know, we also remind ourselves that we need to look at our patient holistically and taking periodontal medicine into it. So thanks for that. First question here, Johann, I have from an anonymous attendee is that in a patient with periodontitis, do you suggest referring them to a cardiologist or medical doctor if they haven't been for a checkup recently?
Right.
You got that, Johann? Yeah.
Yeah, I've got that. So it's very interesting for me to see how many patients that come and sit in my chair in that age group, say 55 to 75, that say in doc, yeah, history of cardiovascular disease, I had a heart attack last year. Then they open their mouths, you pick up a periodontal probe, and they've got aggressive or advanced periodontal disease. And you shouldn't be surprised that these patients had cardiovascular issues before. So yes, if you pick up a patient that is in a high-risk group, for instance, your patient that has periodontal disease is a heavy smoker, is very stressful. Okay, if that patient ticks a few boxes and you're worried about their health, I think it's important for you to tell them to go and see their doctor. Okay, especially if you're not going to do tests for them yourselves, looking at, like for instance, I mentioned their systemic health or blood tests and these types of things. Get somebody to have a look at them. And it's about risk profile. I mean, we all know what these patients look like. If the guy is obese, severe periodontal disease, refer him, send him to his doctor and say, listen, you're not doing too good. I mean, this is outside what I usually expect of somebody of your age group. I mean, something's not right. I can't give all the answers, but go and see somebody that maybe can shed some more light onto why you are having these problems. Go and see your doctor. Okay. So yes, I do think it's important. Then,
yes. No, carry on.
Say again.
No, carry on. You wanted to say something?
Yeah, I hope that answers the question. So I'll go straight to the second one. I can see them on my screen there, Dan. I found them.
Okay, good.
So
Okay,
would
super.
also not increase bone loss? A very important question. So orthodontics on patients that has periodontal disease is not for the inexperienced practitioner. Okay. Yes, bone loss can be like a wildfire in a patient that has active periodontal disease. So the crucial thing is here, a patient's periodontal disease needs to be manageable or managed, okay, before they start with active periodontal treatment. So that patient that we saw, the one that I used as an example here, received stabilization of his loose teeth with wires. We opened the bite to take off the traumatic occlusion, and we cleaned his teeth with optimizing his health and giving systemic antibiotics. And after that, we reprobed him, new periodontal examination, and we established that his periodontal condition was now stable for him to start with orthodontic treatment before the ortho started. Okay, so yes, no orthodontic movements in the patient that has untreated periodontal disease. And another important thing is, he knew from the outset that those front teeth were floating, that they were very loose, and he knew that we are going to keep his teeth for him during orthodontic treatment by putting them, as I put it, on the wire, on the washing line. Okay. And he understood that were going to lose those teeth at some stage in his management. If they become painful, we had a plan to manage them. They didn't. We actually got him through about 90% of his management by keeping the teeth. All right. Do you have to
And
use
Johann,
hand? Yes.
Sorry, before you move on to the next question, when you prescribe antibiotics for your patient, did you concurrently put them on chlorhexidine, or do you first let them rinse before you actually do your root planning on the day? So what I'm asking basically is, do you prescribe antibiotics before you do your root planning, or is it after? And do you also put them on something like a chlorhexidine mouthwash? Thanks.
Okay, good question. Then I don't know how much time we have. I can go back to my screen and I can share some things, or I can just answer. Maybe just easier to answer. Okay,
Yes,
so
thanks.
a very good point to make. I believe strongly in a surgical prophylaxis. Okay. So if I have a patient that's going to have root planing done, we obviously plan it, the patient has an appointment. We start with the antibiotic on the day of treatment. And listen, there's a lot of philosophy here about how many hours before time. I think if we just stick to what is taught in dental school, I think I'm going to stick to that just to not confuse everybody tonight. But if you want, you're also welcome to come and braai with me at my practice, and then we can philosophize about timing, doses, and all these things. But I think in general practice, give a surgical prophylaxis. Okay. So you give it 1 hour before the treatment time, and the dose is 2 grams of amoxicillin 1 hour before. If the patient is allergic to amoxicillin or penicillin, you're going to give clindamycin. And then in the patients with this specific diagnosis, being a severe periodontitis, guys, we're not going to give a patient antibiotics that has a gingivitis or a stage 1 periodontitis with probing depths of 4 and 5 millimeters. If we're talking antibiotics, we're talking about a patient that has probing depths exceeding 5 millimeters. Okay, that's when I will consider systemic antibiotics and the combination of amoxicillin then, 2 grams, 1 hour before, metronidazole, 400 milligrams, 1 hour before. Then, in addition, for my patients that's over 55, okay, which then not two of us yet, hey? I don't like to give codeine anymore. I give them something that has ibuprofen and paracetamol. Okay. Ibuprofen, paracetamol, 400 milligrams, ibuprofen and 1,000 milligrams paracetamol 1 hour before. Give it before the treatment, or just before at least. So, and then the patient has a good swish with chlorhexidine mouthwash, 1 minute.
Yeah.
Okay, right?
Yeah.
So you give your antibiotics an hour before. You give your painkillers immediately before, because then you pick up your local anesthetic and you numb the patient up. Okay. Now, full mouth disinfectant protocol is what we do. Okay. So we do the whole mouth in one hit. Okay. Not everybody can do that. Not everybody's hands can take that, but that's what we do. Or alternatively, split mouth design. I don't like that, because I like the patient to be on antibiotic once off for a period then of a surgical prophylaxis 1 hour before, following through with a full course 5 days after. Okay. If you do a split mouth, then the patient's antibiotics, you either need to do the next day. By that time, you've lost the patient. They don't want to come back the next day to be fooled around. So I often do one hit. If the patient's a little bit anxious, then I am a big user of oral sedatives. In particular, I'm a Dormicum user, not myself, but my patients are. And we obviously, if you use these drugs, you need to have the right protocol. You need to have emergency drugs. The patient needs to be monitored. You need to monitor their blood pressure, oxygenation, and if they run into trouble, you need to know how to manage them. But in general, a 7.5 milligram of Dormicum for patients that's not elderly, okay, for the elderly, half the dose. For the patients with renal impairment, half the dose, okay? So look at the patient, and if you need to do anxiety control with 1 shot, full mouth disinfectant, that's the recipe. So amoxicillin, metronidazole, Dormicum if the patient's anxious, full mouth local anesthetic, 1 hit, clean the teeth. That's it.
Okay,
All
super.
right.
Thanks for that, Johann.
Do
There
you
were a
have
couple.
to use, sorry, yes, say again?
I was just saying, looking at the amount of questions here, there were a couple of questions on vitamin D supplements. For example, is it advisable and safe to prescribe vitamin D supplements to perio patients without doing any blood tests?
Yes, it's safe to do that, but I don't do that. I mean, we are going to give a supplement, then we need to know the baseline.
Yes.
So the answer is yes, you can, but the answer is no, I don't. I test. Okay. We don't just
Okay.
throw things into patients' mouths without thinking and knowing. And that's the explanation. We are going to look to optimize your healing. And for that, I need to send you for blood test. We need to see where you are. Okay. And when we're going to optimize you, how much vitamin D are you going to give? It depends on where the patient's level is. So it's important to know where the level is. All right. Then, do you have to use hand scalers, or can you use a piezo when cleaning subgingivally? What is the risk of using a piezo subgingivally? Okay. Right. There is no risk in using piezo subgingivally. I use the term, we need to clean the teeth. I don't care how you clean them, but they need to be spotless. We need to clean the teeth. So
yeah,
what we do is I start off with my piezo. Okay. I remove the thick stuff. Okay. I use it as deep as the pockets are. Okay, I need to clean all the tartar off. Then once I've done my piezo, then I go hand. Okay, then I root plane the teeth by hand. I clean the teeth using the relevant scaler that's designed for the position in the mouth. Once we've finished with the hand scalers, I go back to the piezo subgingivally, definitely subgingivally, with a piezo or a what's the other word? Electrosurge. No, not electrosurge. There's a sonic scaler. Some practices don't have a piezo, but they have just a sonic. Okay. So a sonic can be used subgingivally as well in the place of piezo. Okay. So I think that's that question.
Yes, that answers that one. Yes, thanks. You can move to the next one, Johann. How do you decide between a 1 month, and a 2 months or 3 months recalls interval.
Okay, that depends on the severity of disease. Okay, so those patients, that's bad. Okay. And those patients that has not looked after themselves and are poor attenders, okay, I get them back after a month, okay, and let them come to see the hygienist and see if they brush their teeth. We often don't charge them, but you can charge the patient as well and say, okay, there's a follow-up on just the oral hygiene education visit. But you need to know that you need to know that they are doing what you want them to do. It's decided then on the severity of disease as well. So
Yes.
somebody that's got severe disease, we see more often. A patient that's got mild periodontal disease, we look at them after 3 months. Okay.
And also there's the tools available, it's just that we don't have time to go into that. I mean, for something like your supportive periodontal therapy, there's a tool that you can use online, and that gives you the recommended recall intervals, depending on, the risk factors, how many PPDs or bleeding on probing, things like that. So our attendees, they can go onto the University of Bern. It's called, the SPT or supportive periodontal charting online. And then you can just play with that tool for your own, assessment of recall intervals. Next question, Johann, for you is, well, it's an attendee thanking you for a well-structured course, for a detailed and structured course of treatment. So that's a compliment. Where do you start with reading up on blood tests, Johann? Any specific journals or articles to start with?
Yeah, listen, this is a hard one. So can you guys recall how much we loved when it came to the hematology block at dental school? Hey, that was just the top one at our priority list. So listen, I hated hematology as a subject, and the thing is, you need to start somewhere. So I obviously have articles. I can email them directly to you for those that's interested in them. But guys, go on PubMed, do a search, go and do an online search, and if you type in those keywords, there's a vast amount of information out there on the net about these things. So just go and cultivate your interest and go and read up on it.
And I think that ties in with the next question then, Johann, because one of our doctors was asking if you can put up the 3 diagrams on the newest classification. My advice will be also to go on PubMed. You just check a new periodontal classification, and you'll be able to find a whole lot of information on that.
Yeah, that American Academy of Periodontics, and listen,
Yes.
that there's that 2017 studies. Just go and put in periodontal classification. I've even had screenshots recently from a patient that asked about periodontal treatment. And he said, well, where do I fit into this classification again? And doc, do I have systemic related health issues with having periodontal disease? And are you going to root plane my teeth? And the question was, are you going to do subgingival scaling of my teeth? Yes, I mean, and patients have got the same, and a patient just puts in these words online. If they can find the information, I don't think it's too difficult for us that's got a medical sense to find the right stuff. But yes, they're available. And if you can get in touch with me, I'll try to help as far as I can. But guys, also, it comes with experience. I mean, I'm obviously not a newly qualified periodontist. Those guys know all the most recent, they can quote all the articles. Hey, Dan, they know all the stuff.
Yeah.
But somebody like myself that's been in practice for a long time, I wanted to give you a flavor of how I treat patients in my practice. Okay, so it was not a highly scientific lecture with a lot of articles quoted, but be under no illusion that everything that I do in my practice has got sound scientific backing. It's not something that Johann Lochner has sucked from his thumb and he just does due to feel good dentistry. This is not feel good dentistry. This is based on sound science, and the science is there. You must just go and look for it.
All
and
right. One
ask.
of our colleagues, yes, Johan, thanks for that, wants to know, is it legally important to conduct a perio probing for every 8101 charged? And I think this maybe we can link it with the periodontal screening, Johan, and the importance of doing a screening, which will then lead to you doing a full periodontal charting. What are your thoughts
All
on
right,
that?
so in my practice, I don't use the code 8101. I use a 8703, which is a specialist code. So I'm
Yes.
sorry, you're going to have to go and look at the descriptor of the SADA code list. You're going to have to go and look at the descriptor and see if you need to do a periodontal probing as part of 8101. And if it's mentioned there, then you have to, yes. But sorry, I'm unsure. I don't use the 8101. We use the 87 code. I use a 8701, which is a basic type of examination. But I do a full assessment. And again, it brings me back to my point. Guys, if you're going to take the time to look at these parameters, you get reimbursed for it. So find the correct code. And it's not about managing your bank balance to do these things. You do it for the best interest of the patient. I mean, it's the patient that comes to you to be assessed, to be diagnosed, and to be managed correctly. And if you don't do a probing chart, you're not going to know what is going on underneath their gums. You have to do a periodontal chart to identify periodontal disease. And so many times I said, Doc, I've been to my hygienist. I go to my hygienist every 3 months. I've seen the doctor every 6 months. You're telling me I've got severe periodontal disease? How is it possible? It's impossible. I've been looking after my teeth well. And my explanation is I say to them, you can only find periodontal disease if you go and look for it. So if your doctor only checked your teeth and didn't look for it, he would not see it. Your hygienist would not see it if she also didn't probe and look for it. So you need to probe to find the problem. That's the only way. You cannot diagnose periodontal disease on just a pan-oral. I made that point. Periodontal disease is diagnosed with a periodontal probing with relevant radiographs, of which a pan-oral is part of. But you can't diagnose just on X-ray. Okay, I think that's clear. You need all the parameters.
Yes, just looking at the time here, and we do have a lot of questions, I must say, which we appreciate. But if I can jump on this one, Johann, from Dr. Nyalunga, the question is, do you use dental lasers as an adjunct to treating periodontal disease patients? Your thoughts on laser treatment?
Randomized controlled trials.
Yeah.
There's randomized controlled trials on these things, Dan. So I often get the phone call and they come to the receptionist, and by now she knows the answer as well. So the question is, does Dr. Lochner use lasers in the treatment of periodontal disease in his practice? And the answer I give is yes. Okay. But a laser is not the silver bullet for treating periodontal disease. It's an adjunct. Okay. So it has its place. It has a very expensive place at the ND-YAG laser, a water laser, one of these things that cost you about about $1 million. Maybe if you get a second-hand one for 400,000 or 600,000. But guys, you can clean the teeth without a laser. Okay. A laser can clean teeth very well, but you're going to have to use a laser in addition to your piezo handpiece and your hand scalers. The laser alone is not going to cut it. Okay. Does that and very important, a diode laser has minimal effect, and that's the laser that is in most general practices. A diode laser is to cut soft tissue. Okay. I also use it to remove difficult granulation tissue parts around teeth when I do flap surgery. But a diode laser is not sorry for using the phrase, the silver bullet in treating periodontal disease. You need to clean the teeth with normal means. Okay, and yes, I'm very sorry to say these things with marketing. I've very recently in the last year, we've had a patient that said, "Well, doc, I've been for laser treatment for my gum disease, and This is the effect, okay? And the effect was horrendous. I mean, horrendously poor. I mean, basically no effect. They did laser treatment, but they didn't clean the teeth. So let me just re-emphasize the importance of the term cleaning teeth. The biofilm needs to be removed, okay? That means, again, supragingival means the visible bad stuff, the white, the chalk, the tartar, needs to be gone, okay? And that needs to be
Yes.
gone supragingival and subgingival. I don't care how you do it. Clean the teeth, okay? And about codes, there's codes for root planing, 8737 root planing codes, hygienist 8159, your reassessment code 8705 is the one that we use. So go and look at your descriptors. There is codes for re-examination. There's codes for oral hygiene instruction. There's codes for hygienist visits. There's codes for root planing. There's codes for local anesthetic. All those things, you charge them and you do them. Okay, sextant, quadrant. Go and look at the descriptor and do the relevant ones. Is it advisable and safe to prescribe without? No, you can, but I don't. Do you still follow older classification of periodontal disease, you nasty person, anonymous attendee? Yes, I've got bad habits too. And I often refer, and nowadays, to be honest with you, if you look at the classification of periodontal disease, we put the proper classification in the patient's record. But the patient has gingival health or they don't have gingival health. If they don't have gingival health, they have gingivitis.
Yeah.
If they don't have gingivitis or gingival health, they've got periodontitis. Okay. So you need to tell the patient that they've got periodontal disease, and that's your ICD-10 code, KO5.3. Okay.
Yes.
That
Maybe
is
Johann.
still an old descriptor, and it says chronic periodontitis. So the ICD-10 codes have, as far as I know it, Dan, has not been updated to address the newer classification, as far as I'm aware. So I use the old one for that. KO 5.3 is the one that's routinely.
I also, correct, yeah. Maybe then, Johann, you can take one more question before we close. It's 2 minutes before 8 o'clock, and then.
Well, thank you, Dr. Marks. Can I tuck my back knee when I serve? I mean, yes, I've got a few issues. I also probably a little bit overweight, so I can tuck my back knee a little bit, and I can put my hands forward and get a little bit more forward momentum. But I mean, we all have our hobbies, and I'm doing it as good as I can. So yes, maybe when we meet in the lineup, I get a few pointers from you on a few surfing tips. Thanks for that. What mouthwashes do you recommend to your patients? Now, this is an important one for me, Dan, and we can go on as long as you want. I've got no kids at home anymore. They're all left. So I can talk about teeth all night. It's my hobby. So for those of you that's got other things to do, you can run for it. But the other ones, you're welcome to stay. I'll answer questions. There's not that many left. Okay, so
yes,
what
I mean, I think the webinar was scheduled till 8:30. But if you're good to go, you can proceed. Thank you.
All right. So the gold standard, as it's referred to, is chlorhexidine mouthwash. Okay. Now, I've started to move away from using specifically chlorhexidine mouthwash to quite an extent. It's not my go-to mouthwash again for patients that has periodontal disease, because your mouthwash doesn't penetrate into the pocket much more than 2 millimeters, Dan. I mean, the research is out on those things. So you treat the periodontal pocket by cleaning the pocket, by cleaning the teeth. Okay, so the bacteria need to be cleaned off. The chlorhexidine affects the supragingival biofilm to an extent, but it discolors the teeth horribly. So that's one of the reasons why I don't like to use chlorhexidine. So we use very little chlorhexidine, but we use chlorhexidine in those patients that has a lot of gingivitis still, a lot of inflammation, and it helps them to remove and it takes away that reaccumulation of biofilm. Okay, but they need to be taught how to clean their teeth properly. That's key, and they need to get on board with that. And
I agree.
mechanical brushing, mouthwashes don't take away plaque. I mean, patients need to brush it off. We use fluoride-containing mouthwashes for the patients that has sensitive teeth. Okay, so that has become quite important for us, and we also use fluoride-containing mouthwashes for our patients to prevent root caries going forward, and that's a huge issue for our older patients, especially those ones that's had periodontal disease before and it's been in maintenance programs for decades. They develop root caries when they're older and they become polyformed. I mean, when they're on 10 different medications. Xerostomia, rampant tooth caries. So extremely important. I'm still a big believer in fluoride-containing toothpastes. Okay. If there are certain brands that's advocated for sensitive teeth that specifically has no fluoride in them, I am against those mouthwashes. So my comment is, look under the ingredients, it must have fluoride in it. And most of the high fluoride containing toothpastes in excess of 1,100 parts per million, those are the ones that we advocate.
Yes.
High inflammation patients, yes, chlorhexidine, but in general, chlorhexidine I don't give for extraction patients anymore. It gives dry sockets. Okay. No salt water rinsing. Salt you put on your food, you don't put it in your mouth. At the concentration you're going to use it, that is medicinal. I mean, you need to have a saturated dilution of the mix you may. So it's got feel-good dentistry behind it. It hasn't got science behind it. So I don't use those things, especially for extractions. No chlorhexidine, no saltwater mouthwashes. If it's sensitive, yeah, clean carefully. We can use mouthwashes after about 2 days after extraction. Otherwise, the blood clots last. So I hope
Yes,
that clarifies my chlorhexidine.
Yes, related to chlorhexidine, Johann, is the question on what's your opinion on hypochlorous acid mouth rinse instead of chlorhexidine?
I
must say
don't
I'm
use
not
it,
familiar.
Dan.
Yeah.
So my experience with it is limited. But I mean, COVID, we used a lot of the stuff, eh?
Yeah.
And it's cheap. Yeah, I think it can be useful.
Okay.
I had a patient actually, funny enough, today that said how much hydrochlorous acid, how much relief she gets by using that when she has issues with a desquamative gingivitis with lichen planus. So she can't tolerate chlorhexidine, your let's say gold standard. She can't tolerate that. It burns her too much. But she found the hydrochlorous acid quite useful. So yeah, use what you feel you have to use. Why has routine root planing become unpopular amongst periodontists? I cannot say, but in my practice, it forms 90% of what we do. What is your opinion on using hydrochlorous acid? How many hours does it take to do a one-hit root planing, such as the patient on the webinar? Okay, that's an important one. So, guys, it's not a 15-minute job to clean a patient's mouth. It can take between 1.5 to 2 hours to do a full mouth root planing, and it depends on severity. It depends on access. Okay, how easy it is to get to those difficult areas. The patient can't open their mouth for so long, so we use bite blocks, okay, to stabilize while we clean certain parts. And you don't start off by numbing one hit, the whole mouth. You start, I often do the maxilla, one hit, numb the whole lot. And by the time that I get to the last 3 or 4 teeth in the upper, then I block one side in the lower. And by the time I come to the second or last tooth in that side, I block my last side in the lower. If the pockets are just lingual, obviously a block would be enough in the mandible. If the pockets are buccal and lingual, obviously you need to numb buccal and block in the lower. Same goes for the maxilla. If it's just buccal pockets, buccal infiltration and palatal infiltration. If those palatal pockets are 5 millimeters or deeper on the palate, it's not good enough to just give a little bit on the buccal. And then when it comes to local anesthetic, we use a lot of articaine. The penetration of that is amazing. We can get away with a lot less articaine than your classic lidocaine or mepivacaine. So that's my preference when it comes to local anesthetic. I hope that answers that question. But in general, we start off by booking, if it's not too severe, 1.5 hours is the starting point, but it can take as long as 2 hours. And then it comes again, listen, if your hands are not capable of doing that, there's no point in booking at 2 hours if you can't do 2 hours. You need to be a marathon athlete when it comes to tooth cleaning to be able to do that. So don't think you're going to do it from day one, that you're going to do a 2-hour root planing for a patient. It comes with experience. It comes with spending a lot of time in patients' mouths, and then your hands get used to it.
Yes, next question from Leslie. Yes, you can take that one, Johann.
What is your take on using tetraclocyclines as antibiotics instead of amoxicillin metronidazole combo? Okay, so listen, the research on this is clear. It's a von Hinkelhoff cocktail, well-researched, randomized controlled trials, and that's the standard of care that is researched for periodontal treatment. Amoxicillin with metronidazole. Okay. Now, I do use, and you probably refer to Zitromax. I use that in my patients that's allergic to penicillin as an alternative. The Zitromax is very useful because it has that potent anti-inflammatory effect as well. But the research is not unequivocal on that, Dan, as far as I'm aware with the use of Zitromax. So I think, do I use? Yes, I do use. I use it for my allergic patients. Do we test sometimes the need? Do we do genetic tests and bacteriological analysis for patients? Yes, we often do. And from those tests, I've over the years just seen that those patients that's got deep pockets, I'm talking about patients with pockets exceeding 5 millimeters. They have AA often, and Actinobacillus actinomycetum comitans. Then there's some new names for these bugs as well. I can see you also smiling. So yes, new names, specific cocktails for specific bacteria, but those bacteria live in deep pockets and they hate metronidazole. So metronidazole is a horrible drug. Patients will say, Doc, I'm allergic to flagyl. Then I'm saying the allergy that you have, if you say that you've been nauseous to it, is not an allergy. I need those bugs dead. I would love you to take your metronidazole if you can. They must take, I asked them to take it with their last bite of food. Okay, so that thing is with a full stomach, it's in there. And then in general, it's less nausea. But metronidazole can even give you nausea if you just take cough syrup with alcohol in it. So really very important. Your patients can be highly sensitive to metronidazole when they have alcohol, and that might be the reason why you've got poor results with it. As a general dentist that uses blood tests regularly, besides the online support, the pathology labs have booklets they will share with, and okay, so there we go. That's a useful, thank you for that, anonymous attendee. I am Dr. Lochner, not so anonymous attendee. In perio, a dental systemic genetic combination disease. Is perio a dental systemic genetic or combination disease? Goodness, it's everything. And the more, what is the word? The more, the contributing factors you have, the more severe the disease. So you can have a patient that's just genetically predisposed and they can have bad disease. But I call it a perfect storm. If they smoke 20 plus a day, if they have diabetes, and if they've got a mouth that has got visible biofilm everywhere with deep pockets. Those are the 4 big ones. Genetic predisposition, smoking, diabetes, and bad biofilm. Those are the 4 number ones. Then together with that, stress, obesity, cholesterol, blood, dyscrasias, okay, your blood profile, your immune system not working optimally. So those things are not even big four, but I've seen in my practice, by optimizing the healing, by looking at blood profile, we've made a huge difference in healing and we get good results.
With the immune system not working, Johann, how often would you then test for HIV or RVD status of the patient?
Then I've done in my private practice in the last 25 years, I've done less than 10 HIV tests.
Mm.
Okay, so that general, listen, that's a tough one, you know. I know in certain areas it's rife, and you would know that the clients that you have probably would benefit from one of those tests. So in my practice, not done commonly,
Yeah.
but we pick up those patients. If we see that they've got a low lymphocyte count with their full blood count that we do, and they don't respond to treatment, and then, yeah, we say to that patient, listen, something's not right about your blood test. We see that your lymphocytes are not what they should be doing. Your immune system is under stress, and we don't know why your lymphocytes are low. We need some more tests, and that's when we'll target that group of tests. I hope that answers that question.
Yes,
so as a
thank you.
standard, we don't ask for a specific lymphocyte specific test. We just do the full blood count.
Yeah. Okay, the next one from Shamina was a compliment. Thank you, Dr. Borat. The one from Shahina Sultan. 8102 is the general dentist code that includes period charting.
Okay, there you go. Thank you for that.
Okay.
Shahina.
And another one was a complimentary one for the excellent lecture. And do you have any thoughts on irrigation of periodontal pockets with diluted sodium hypochlorite solution after cleaning or scaling and root planing?
I have no experience with that. I would be very careful about the concentration that where you dilute it to. In my view, you can use sodium hypochlorite inside the pulp of a tooth to do root canals. I don't have any experience or any knowledge about using it as a irrigant around
not in the
pockets.
Yeah, not in the
so
pocket.
In general, just an important mention that I want to do there. So after you've done your cleaning of the pocket, you've done your piezo handpiece, and you've done your root planing. Remember, you now need healing, okay? And healing is triggered by the formation of a stable blood clot, okay? So once you've cleaned the teeth, you basically let that pocket will bleed profusely where you've just stuck your instruments in, being it 5-8 millimeters deep, and you would have created a lot of blood there, okay? And the best thing is to not disrupt that blood clot. And what disrupts it is washing your mouth with salt water, rinsing your mouth with chlorhexidine afterwards. So I don't advocate irrigating that pocket. I mean, you obviously irrigate the pocket while you're doing the root planing with water. I mean, and some practitioners use a diluted chlorhexidine rinse in it. We don't put anything. We just use normal water, and we don't irrigate pockets afterwards. I do when I do surgery, and I do open flap surgery after I've cleaned the root surfaces. I do wash the root surfaces then with saline, okay, to make sure that everything, all the little bits of debris is removed. Before we then, if we do grafting of pocket areas, then obviously we would rinse with saline, we would treat with Pref gel and the relevant biologics. But no, I don't know about hypochlorite. Is it safe to do bilateral mandibular blocks? A demonstrator at dental school once said you should not paralyze the whole tongue. I think it's clear from my protocol that I do not concur with that comment. Okay, but you've also saw that I obviously don't block the patient from the outset, both sides at the same time. Okay, but the patient will be numb, being blocked both sides during their appointment. Yes, at some stage that whole tongue will be numb. And you warn the patient, you say, listen, we're booking an appointment for you. It's going to be an hour and a half or 2 hours. We're going to numb your whole mouth. That's why I want you to eat beforehand. Don't come hungry. We are going to give you your medicine before we treat you because you won't be able to swallow so easily after and during your treatment. Okay, so your mouth is going to be very numb, including your tongue. So nothing to eat until the injections are gone. You can drink after the treatment. Okay, otherwise you're going to bite your tongue. So yes, very important. You need to mention, it's not a surprise when that patient has a bilateral block. They've been informed beforehand that their tongue's going to be numb. I've had a double block myself, Dan, when they pulled my wisdom teeth in my 4th year. I had a double block. I'm still here. I didn't swallow my tongue. It was horrible.
Yeah,
but it's
and
done.
you lived. Yeah, I think it's important to give post-op instructions, yes, more than
and
anything.
pre-op, warn.
Yeah, yes.
Some patients would say to you, Doc, I can't sit for an hour and a half. You better break it up in 2 parts. Then I say, that's not our preference. The reason is having one-time antibiotics, not postponing it too long. So would you be able to come 2 days after? It's not ideal, but we can do it for you like that. Yes, we can. Patient with a sore jaw, I can't keep my mouth open so long. I've got TMD. Then we can do shorter appointments, but it's not the ideal. What toothpaste do you recommend? Yes, we do use Periodontics. Yes, we do use gum products. Yes, we do use Meridol. We use Elmex. Listen, you've got my point there. I'm a firm believer in toothpaste that's got a certain amount of fluoride. Those things all have them in. It's for me about taste. Okay. Mechanical action of cleaning the teeth. It's not the Periodontics, the gum or the Elmex or the Meridol that has the effect on periodontal treatment. It's about you telling your patient how to clean their teeth properly, and they cleaning their teeth properly, and you're able to have cleaned all the supra and subgingival calculus off of your root planing. That's what gives the result.
And that's where the plug.
Yeah.
Yes,
but
that's
the
where
products,
the plug index.
The products are important. So yeah.
Yeah, that's where the plug index comes in, where you can actually demonstrate to your patient with the use of a disclosing agent to see, look how well you're brushing or not. And you use that as a motivation tool, to concentrate on which areas to clean some more. Okay, 2 last questions, Johann.
All right, probiotic, yes. And very important here. Listen, you'll hear from the recipe that I use amoxicillin, not augmentin. Okay. So if you use, there are certain patients that has very aggressive disease that we test beforehand, and their bacteria needs clavulanic acid in addition. For them, we do use augmentin, metronidazole combination, but standard amoxil metronidazole. And the answer is absolutely yes. We use probiotics. We use probiotics for all our patients, especially the ones that gets augmentin, even if it's just alone. The ones that get double antibiotics, the dual therapy antibiotics, all get probiotics. And those patients, especially the ladies that tell you, Doc, hell, do I really have to do this? I mean, I've had the most horrendous fungal infection after the previous ones. We try to, yes, absolutely, probiotics. Box supporter, whose presentation was excellent. Thank you so much. Yes, it's nice to be supporting a team that can win and lose with dignity.
Yeah, for sure.
A patient asked a delicate question. Did oral sex lead to his periodontal condition? Right, so listen, if you share the bacteria, you can transfer the harmful bacteria. Okay, so we get the biofilm that we use, the genetics, the genetic makeup of the bacteria in our mouths come predominantly from our mothers and the family members that we share with. So yes, I suppose it can have an effect in your biofilm becoming more harmful, but not from oral sex. I mean, the bacteria that's periodontal pathogens are not ones that, as far as I know, come from those sources. But more important than oral sex is just normal open mouth kissing, sharing saliva that shares biofilm, that shares bacteria. So not necessarily oral sex, although there are certain bacterial groups. Let's not elaborate on them on an evening like this. But yes, there are certain harmful bacteria that is linked to periodontal disease that come from areas that some people will use as, let's say, beneficial areas for their sexual practices. So answer is yes, but it can theoretically. But I would say that's the major source.
All right. I think that was, yes, that was the
yeah, thank you
last
so much, Dan.
there,
And thank you
Johann.
for all the compliments. It's difficult to pitch a no where 200 odd people want what they want to know. So, like I said, I gave a lecture on what I do in my practice, and with my experience over many years, there's some of my colleagues that would do things differently, but this is how I do things. Trying to look
and
after my patients
perhaps on that
as good as I
Johann,
can.
you can share your email address for those who did ask questions and maybe we did not get to them. You want to just share your email address with our attendees?
Yeah, can I just read it out? It's DOC at Johann with 2 N's, Lochner, that's LOCHNER.com. And I mean, I'm also on the World Wide Web. You can Google me. My contact details are right there. I can't hide anywhere.
Okay. All right, super.
But you're welcome. You're welcome to send emails for advice. I'll try to respond as quick as I can. But if it's urgent, if you need somebody like us urgently, and then you phone reception and you say, listen, I've got an urgent problem. I need to speak to the doctor. And then they come with the phone to my ear and they say, listen, the patient's not breathing, or they've got a very loose tooth that needs to be stabilized. Please be helping. Then we try to help.
All right. On that positive note, let me thank you once more, Johann, for always being available, to give such talks and all your support that you give to SASPIO. And on behalf of SASPIO, we really would like to thank you, and also with our sponsors from Colgate and SADA partnership for making this webinar possible. And to you also, ladies and gentlemen, thank you for staying in attendance until this time, and your participation in this webinar, and all the questions that you asked are most welcome. And with that, have a good night. Thanks, Johann.